So today, I want to thank the New York State HIMSS chapter for having me moderate this and pulling together this presentation of VR, AR in healthcare. It's a little snapshot of where we're at in summer 2020. I'm just going to present a couple of slides on how I got involved, what I'm doing, and then turn it over to our panelists. We have a couple of different perspectives from providers and solution developers and educators, and I think a nice mix of people today. So by way of introduction, my slides aren't moving. Sorry, Mark. There we go. My name is Joe Desiderio. I have a long background in healthcare IT. Prior to that, corporate IT. I've been involved in the speech recognition and workflow automation corner of healthcare, going from 2002 to 2019. About 15 years of experience in surgical pathology informatics with speech recognition, workflow automation, structured data capture for cancer reporting and things like that. In 2019, I started Connector as a way to do some consulting in advanced technologies, primarily VR and AR. And I'm also actively involved in an organization that looks at best process for strategic alliances, a lot of pharma influence and big tech influence there, and also Data Visualization Society, which is sort of a love and I guess a labor of love for me at the moment, but it connects to some of the things I'm doing, so it's up here on the board. A couple of personal dots. When I first started in IT, my first mentor threw up this IPO chart. No idea what he's talking about. I thought he meant Wall Street IPOs, but input, process, and output. Very basic, sort of simplistic concept in systems analysis, but it's something that just jumped out to me as I was thinking about this. When I started in computing, we had keyboards. We just started getting the mouse. In about 10 years after that, voice was becoming a thing. It still was early. And now we're at a point where we have sort of an explosion of eyes on that chart, gesture, computer vision, all the way through smell and brain-computer interface. And these are all things that excite me as inputs in combination with each other and in context with delivery through VR and informing VR solutions. Lessons learned from voice is something I would love to talk about. I'm going to push that off for today. We don't have time, but if anyone's ever interested in covering some of this, there are a couple of foundational things that used to happen in voice where it was very complicated to build a solution. We had to add digital analog boards. We had a custom program, and now you just plug in a little hockey puck. And these are things that I think are happening also in the VR space, and have a very sort of niche-y little background there that I love to talk about this stuff, but again, for today, we'll push that off. Some basics on XR. I use XR, like a lot of people, to just stand for virtual reality, augmented reality, and mixed reality. I don't like to spend a lot of time on this. Walter Greenleaf at Stanford just put it probably the best I've heard in the last few years. It's a spectrum of immersion. Virtual reality, you're fully immersed. You don't see your real reality unless you're playing a game where you start to go out of bounds, and then the headset gives you, an image. But it's a spectrum. So you're fully immersed when you're virtual. You have a mixed reality at the other end of the spectrum where you're seeing virtual reality and your actual reality, and augmented reality, the old Google Glass model, where you're seeing an overlay of what's happening in reality. And there's solutions across all of those in VR that are exploding right now. As of summer 2020, we have a wide variety of form factors, head-worn devices ranging from $400 or so, the Quest, and things like that, all the way up through Varjo and more advanced headsets spanning, more than $10,000. Suitability to fit an application, driving, which headsets get used, of course. And there's a giant range of use cases and users, from clinical use cases for patients and providers to non-clinical things, even into facilities management, soft skills training that have associated a big range of applications as well. I'm not going to try and present all that in 5 minutes, but just a little context on how I'm looking at this. And the other great quote from Walter at Stanford recently was, it might be easier across all the specialties to talk about the specialties that are not involved in VR. It's becoming ubiquitous. Sorry. I'm not advancing. Oops, there we go. And then from recent activity, particularly back in March, the last sort of non-virtual meeting that I attended was in March in Silver Spring at the FDA. They had their first ever work meeting on how the FDA looks at VR and AR. It's in parallel to the activity they have going for regulation of medical devices and software as a medical device. They're now looking at VR and AR and trying to help the solution providers understand what it takes to get applications cleared and ultimately approved for therapies. XR Health was probably one of the first ones to get approval. Many others are adding to that list. Beyond the FDA, the digital therapeutics category broadly, every large pharma company now has a product development lane for digital therapeutics, mostly looking at phones and tablets, but it is starting to lap over into the headset space. And we're going to see a lot of different vendors, partnerships happening in that space. Acceleration of telehealth, obviously with COVID, telehealth is up something like 4,000 times, a lot of crossover with VR and AR there. Alliances, as I mentioned, starting to take off. You'll see those in the news. I didn't grab a bunch of them. It's another side topic. If anybody wants to talk about that, happy to do so. And COVID, just personally, I got my first headset finally. I was waiting for a Quest for, I think, 3 months. I think there's a lot of acceleration and also some deceleration with constrained supply and things like that. Couple of quick shout outs to the conferences that have happened recently. Cedars-Sinai has a great one. Dr. Spiegel at Cedars has a book coming out in October that I would encourage anybody who's interested to take a look at. The International Virtual Reality Healthcare Association had a nice session with all these presentations are online. So if anybody wants to catch details, these are great places to go. And coming up in September, oops, I missed a little either in Heidelberg, sorry, Heidelberg. Dr. Riedemann at University of Heidelberg is putting on a session called Shift Medical. And again, if anyone's interested in the details, please go check that out. From a New York flavor, since it's New York State HIMSS, Rochester just got recently had a solution approved for vision correction with VR headsets. Over the past year or so, I've bumped into locally here in New York City area researchers from Mount Sinai, NYU, Weill Cornell, many others. We have some good resources in Brooklyn at the R Lab. The New York City Media Lab is also involved, and Lehman College up in the Bronx does a really nice course on VR, VR programming if people want to get involved with that. I'm not going to run through all these, but I just wanted to sort of touch on, and there's many more behind this. There's many organizations here in Metro New York City doing work in VR, AR at a research level, at an education level, and even into like surgical planning and surgical assisting in fine needle placement and things like that for biopsies. Okay, that's all I have on slides. I want to jump it over to the presenters, starting with Tim Fitzpatrick from Icona, who I met recently, who's doing a great job in education. And Mark, if you can switch us over.
Good to go, Joe? All right, thanks for the introduction, really appreciate it. Let me get rid of this down here. All right, hello everyone. As Joe said, my name is Tim Fitzpatrick. I am the CEO at Icona Health based in New York City, and our focus is really to use immersive technology as one part of our approach to improve education and training in kidney care specifically. Thanks HIMSS, thanks Mark, thank everyone who's involved in putting this together. This is a great event and a great panel, so I'm excited for you to hear all of our perspectives. Before I get started, if you have any questions about what I cover here, most of it should be covered on our website here, icona.health. And please, any questions we don't address in Q&A or I don't cover during this 12 to 15 minute presentation, just go ahead and reach out to me directly. I'm happy to answer any questions. So our story is, if you're not familiar with it, it really starts several years ago. I was in the US Navy and ended up spending 18 months and close to 2 years in the VA health system as a patient. So that 18 months was mostly wound care, several hundreds of painful wound care treatments, several surgeries, wound vacs, complete isolation for the most part. It was terrible, but what happened as a result, and once I healed and was healthy and moved to New York and started working in finance, I realized, hey, these problems I faced were not just mine, right? I had several challenges that I faced, many of which were in education, just understanding what's next, of course, therapeutics and pain management, that sort of thing. But I started to ask, as I was working in finance and covering tech, media, and telecom, what could have been different? What could have been changed? And it was around that time that I met my two co-founders, who were neurosurgeons based in New York as well. They had done this wonderful RCT about the patient experience. So how do we use VR as a perioperative tool to help prepare patients for surgeries? And we're talking agnostic to the type of surgery. This is more just a day in the life of a patient. How can we help them reduce anxiety and increase their overall experience in that perioperative setting? And they had done this in 2015, 2016. So by the time I met them, I had already been the patient, now good friends of mine, of course, but I knew right away that it was going to be powerful. So we started asking an interesting question. How do we impact health literacy? Because that's what we ultimately wanted to help address. I had faced a challenge here, but I knew that there are many contributing factors: age, education, low English proficiency, socioeconomic status, plenty of contributors that go into why someone might experience low health literacy, but the numbers were much higher than I ever anticipated. And I struggled with this myself, and never would have expected that, even though I'm generally literate, there are many differences between general literacy and health literacy. So we started to ask, who's most impacted, and who can we take this great RCT, this promising idea with, and apply it to a population that we think could have a tremendous benefit of being able to see what's going to happen next in their care. So a few years ago, we started working in kidney disease, and in particular, we were helping patients who were on dialysis. So these are patients with kidney failure, stage 5 kidney disease, who were deciding between treatment options. And we were helping to facilitate that, because it's this in particular, you can see here, nearly 40 million Americans have kidney disease today, and 1 in 3 is at risk. And the reason is leading contributors are diabetes, high blood pressure. There's a good reason why 1 in 3 Americans is at risk of developing it, but almost 90% of folks who do have it aren't aware. So our goal was, how do we help those who have just found out, hey, my kidneys have failed, I either need to have a transplant or go on dialysis, or not, or conservative management, but that's a difficult decision. So how do we take this great concept about using VR to familiarize people, to immerse them, and apply it to this group? And so we started working there 2.5 years ago. To give you an idea, in New York State alone, over 45,000 residents who have kidney failure. That is just stage 5 kidney disease. There are 5 stages, and when your kidneys fail, it's called ESRD. That's who we're talking about here. So these are folks who are likely on dialysis, and there are almost 300 centers just in New York State alone, and over 4,000. These are a few years old now, but over 4,000, probably close to 5,000 employees in dialysis centers in New York State. So both from the patient perspective and from the employer perspective, there's a massive challenge here in helping patients make decisions about their care. And in this use case in particular is a very powerful one for immersive technologies. Another reason why this challenge we're facing and trying to address is so relevant right now is, a year ago there was a new bit of legislation passed, and it's a big deal. It's going to lead to a very incredible shift in what's happening across the industry and how patients receive their care. And that shift is this: only about 12% of patients, U.S. dialysis patients today, receive their treatments at home. What this order says is over 80% of patients need to be either at home or receiving transplants. So it's a significant shift in the way patients experience their care. So of course there are challenges there, and the challenge is, how do you help the patients understand what their options are? If if we know that this has to happen, well, patients still need to be involved in that decision-making process. So we have to have better ways of educating them about their options, getting care teams prepared to have discussions about those options. That's the second part. So training these care teams to be able to facilitate this decision-making process with the patients. And then that last part is interacting with both sides of the point of care so that both parties are equally informed on the same level. Health literacy is where it needs to be, and the confidence is where it needs to be for folks to make the decision that's best for them, whether that's going home, getting a transplant, or not deciding to get the treatment. So what we realized, let me get rid of this here. All right, what we realized is we need to have a better way for patients to learn and for staff to learn as well. It needs to be effective, and all of that needs to hold true, but we also need to be able to measure how well that education is landing, because you can introduce a new technology all day, but unless you really know how well it's impacting this particular decision point, it's not going to do you much good. So we often hear about patients who had no idea about a basic level of understanding of kidney disease, and physicians, nephrologists, nurse practitioners who visit with patients and then say, well, I don't really know if they're retaining the information that we're giving to them. So this is our focus. Our focus is learning performance and subjective measures using immersive technology. All right. And our mission at ICON is to educate 10 million people affected by kidney disease by 2030, over the next decade. That's patients, family members, loved ones, all stakeholders, frontline professionals, care professionals, physicians, anyone who's impacted by this disease. We want to help educate everyone involved so that decisions are made more smoothly and care navigation is much easier. And here's what a product looks like. Here's what our product looks like for the kidney care ecosystem. It is a multi-platform approach. So immersive technologies, as I said before, are one key component to how we deliver certain types of information. And it's important that, especially in today's world and environment, access is critically important. So these are patients and families who are at risk. They cannot necessarily get access to a VR headset at all times. So we take a multi-platform approach. But more importantly, having an effective delivery tool is not the best case in all cases. So I'll get into use cases here in a minute about when is the appropriate time to use certain tools in your arsenal if you're educating patients, and that is why we have the multi-platform. So the three pillars for us are clinical expertise. That's what you need to know. What does a patient need to know to make this decision? What does a frontline caregiver need to know to be able to talk to this patient? The second bit, and there's plenty of that, by the way. There's no issue with access to critical health expertise. We know that there's plenty available out there today on the internet or handouts or conversations. The challenge that we've seen and what we try to address is in how it's delivered, the how and when you need it piece. So learning delivery is informed by learning science. Our team, Todd Maddox, if you follow his work in writing, a lot of our writing together is all about what is it about the way we learn, the psychology behind the way humans learn that will help us inform the ways that we teach patients and when that happens and what that format should look like, whether it's VR or two-dimensional video or conversation. And then finally, storytelling. VR 360 video in particular is fantastic. It's the best tool we've ever seen, and it's very powerful and it's measurable, which we want to use anytime we can if there's an opportunity for familiarization for patients or staff. And as I mentioned before, the ability to measure how a patient feels when they are transported into someone else's perspective, and to be able to have a discussion when they take that headset off 5 minutes, 10 minutes later about what did they experience, what was it like, what did you feel, how are you feeling now. We want to be able to capture that, and it's important that we do. Now this is the last slide here on product, but an idea of dashboard and the ability to truly have that multi-pronged approach of controlling delivery, so you have your best educator every single time for every patient. There's a lot of variability at the point of care. Time is a huge factor. Lack of confidence and comfort talking about certain subjects is a big factor. We want to control that and have the best possible experience every single time. Optimal learning, so as I mentioned, right format, right time, right modality, and then easy to use. It's important, and you'll hear later from another presenter, how important it is to have a tool that works seamlessly the way you do things, that just enhances your ability to understand patients. We cannot have barriers in how we implement these technologies, and it's also, you get the greatest product in the world, and if it makes someone's life more difficult, you can't expect them to use that and to use it effectively, and they shouldn't have to. So here are about use cases. I would say our use cases fall into two general buckets. The first is provider-led, so some sort of one-to-one or one-to-many education style. Let's say it's centralized in a hospital, at a clinic, at a dialysis clinic, with the doctor's office, with a nurse who is visiting you bedside or visiting you in the home. They are driving that experience. They provide the headset to the patient. They are there to monitor what's happening. They are there to answer questions afterwards and have an informed discussion. Then there's user-led, and this is where you might have a patient who has made the decision to go home and receive treatments there. Well, they need to be given a course of training to get them ready to start that new treatment. Or we need a patient who feels more comfortable going home and being discharged with a PICC line. You name the situation, but there are plenty of opportunities for VR as a standalone solution to put on a patient and to allow them to drive their own learning. But of course, no matter what, we want the data, we want the information we're gathering, that experience, to always go back to those who are providing the care and managing the care. Here's our impact just on the VR side so far. I think we're now in 25 states, well over 200 locations at this point, and our objective measurements of increased understanding for patients and staff, the blended average is 52% increase with VR experiences and objective assessments. 4 in 10 patients have made treatment decisions as a result of a single VR experience, which is incredibly powerful. We look at not only magnitude of how often decisions are made, but over what time period. So there's more coming on that soon. And then lastly, 80% of patients have preferred our VR education to traditional methods they've used before we entered their lives, which is fantastic and just speaks to which interaction you typically use VR with. Now, we use it early so that we can immerse someone and give them a great idea of what this option is, and then we can dive in later with the traditional forms if that's most appropriate. But VR is really landing well with patients of all ages, by the way, because kidney patients tend to skew into the older category, and we're not seeing usability issues often. Of course, we'll still have them, but it is not what most people expect in terms of usability. And then last thing here for me is just where to find us. So we're online, we're very active on LinkedIn, sharing research every day. And then please take note of my email address if you have any questions or want to enter our Learning Hub, the bottom left corner, where we have, I think, 400 peer-reviewed articles on all applications of XR across healthcare, and it's sorted by clinical focus area as well. So thanks so much. All set here. Thanks, Joe.
Great, thank you, Tim. Yeah, for anybody who doesn't know Tim or Icon, I very much encourage them to go to his website and go to look at the Learning Hub. There's constantly new updates about foundational research and how to put some of the stuff into practice in clinical settings. And you guys have been a really great resource as far as sharing that information. I really appreciate that. Okay, next up we have Howard Gurr. And continuing the New York State of Mind connection, Howard is a therapist here on Long Island, and I'm going to turn it over to Howard to do his intro and present. Thank you.
Thank you, Joe. Happy to be here. Anywhere where I can talk about virtual reality is a place I'd like to be. And anytime I can educate people about virtual reality and its uses and benefits, I'm always there. So I'm very happy to speak to your group. So let me start with who I am. I'm going to have to date myself right now. So I'm a psychologist. I opened up my practice in 1983. My goal was to be Bob Newhart, if you remember his TV show, where he was a psychologist, and he kind of like went in the morning around 10 o'clock every morning. He kind of fooled around with the people in the office. He was home for dinner every single night. I thought that was a great life to have. Well, it didn't quite turn out that way. And I wound up working extremely long hours. I would leave the house before my kids were up, and I would come home after they were asleep. So for days and during the week, I wouldn't even see my own kids. So technically speaking, my place here is I'm an end user. I'm not a developer. I'm not a researcher. I'm the guy who uses this in the clinical sphere. So my experience with VR started around 2003 when I came across an article on Skip Rizzo's virtual environment for attention deficit disorder. And he had this classroom with a lot of distractions and a way of measuring, eye location and head motion. And I thought that was phenomenal. So I reached out to Skip, but he already shelved it at that point. And in fact, I think he sold it to a psychology publishing company, and they canned it themselves. So it went nowhere. So I was kind of disappointed because I thought this was really great. This is the way to measure attention deficit disorder, as opposed to what we were using at the time, which was parent rating forms, teacher rating forms, kids rating forms, and then things like the TOVA, which was a measure of attention on a computer. But all of that was correlational data and not very strong in my book. So I was back to square one. At the time, just to give you the background, I'm a licensed psychologist and a certified school psychologist. So I did both jobs at the same time. So I was working in a school district at the time and working part-time in a practice. So I was really running two fields and two jobs. So that's why I was interested in the ADHD component. Anyway, I got quiet again for a while, and then 2008 to 2009, I got a bug again, and this time I was looking for portability, and what I really wanted to do was provide services to executives who had public speaking anxiety, and I wanted to go to them as opposed to them having to come to me. So the only game in town at that point in VR history was Virtually Better. And so I spoke to them and asked them about the ability to be portable. And they said, no, it doesn't work that way. You need more processing power than you could find on a laptop. So I was back to square one. And their business model was a little off-putting to me. It was very expensive for the user because they were really focused on research, universities, and hospitals. They weren't looking at people like me. They were looking at the VA. They were looking at people to produce a lot of research and data. So I was kind of like at the low end of their spectrum, and they weren't very interested. And then around 2016, I was at a conference on technology and private practice, and the presenter just kind of threw out as an add-on about a company in Barcelona called Sios, and how they had figured out how to use Samsung phones and head-mounted displays to actually come up with virtual reality environments that were immersive enough to actually work. And I was like, this is it, I'm ready. So I spoke to their representative who came over to my office and demoed the system for me. And so he put me in a bunch of virtual environments, and none of them were getting me. In other words, he put me on a plane and he said, so how do you feel? And I said, fine. Whatever environment he put me in, I was really okay in. And I was thinking, maybe I made a mistake. Maybe virtual reality isn't quite ready for prime time yet. And then he said, okay, let me try one more thing. And personally, I'm not great with heights, so just keep that in mind, which is an interesting phenomenon that happened to me many years ago, where all of a sudden I had difficulty with heights. And he put me on the edge of a building and on a balcony and asked me to take one step. Now, my brain knew I was in my office. I understood where I was. And he said, okay, take one more step. And I said, I don't think so. I wouldn't take the step. And so I realized at that point how significant the presence was and how my brain really was hijacked. And I understood that if I had patients who had anxiety in specific areas, that they would have the same emotional reaction as if they were going to be faced with it in vivo in real life. So I got it. So I bought the system on the spot and spent several months bothering all my relatives and friends and making them go through all of these environments just because I wanted to polish my skills. So I didn't want to introduce it to my patients before I felt confident in it. Now, as I said, I opened my practice in 1983. I'm cognitive behaviorally trained. And so CBT is, the basis of CBT is that thoughts create problems. Thoughts create emotional reactions then create behaviors. And you get the thoughts in line and you teach people how to deal with their thinking, you reduce their anxiety level. Now, about 9% of the population have specific phobias, and about 5 to 12% of the population have significant anxiety disorder. So that's a big chunk of the population of people having problems that need to be addressed. And in the old days, prior to VR, if I had someone, let's say, who had a fear of flying, I had to rely on a couple of things that were really not really helpful in the long run. So if I'm working with them in the office, I had to have them sit in the office and I would say, okay, let's close your eyes and let's imagine you're on a plane. And we would go through all of the potential environmental factors that I needed to incorporate in their thinking. But in reality, people have a lot of difficulty holding on to the image that they're fearful of. And why would they want to do that? So it's very difficult to get them to keep holding on to that image. And so what happens is eventually, unfortunately, lots of people drop out and don't complete, the program. The next level is, well, I got you through all of the, imaginative situations. Now we have to put you on a plane. And again, it was a lot easier to do that prior to all of the security issues. So you would take somebody on a plane, fly to Philadelphia, and then fly back. So it's a short hop, and then you'd work through all their anxiety. Well, that's time consuming and expensive, and now very problematic. So with the introduction of VR, all of that was taken away. So when I started using VR for my patients, I would have them in the office. Let's say, again, we work on fear of flying, and I put them in a virtual plane with a head-mounted display, and their brain gets hijacked. And so they're now, part of their brain is in that plane, even though intellectually they know they're here. So the front part of the brain knows they're here, but the back part of the brain, the more primitive part of the brain, is hijacked. And so I then they start to experience the same anxiety reactions that they would being on a real plane. Now I have the opportunity with VR to work through all of their experiences and retrain their brain so that it doesn't react the way it does in terms of this, amygdala immediate response. And so I'm retraining them. And the thing about VR for me is it's not just VR. So I need to use the CBT, the VR, and mindfulness and anxiety reduction all at the same time, because that's the way I could get to their core problems. And so VR is, in my book, a tool. And I know that there's this whole issue about FDA approval and whether it's appropriate. But in my book, if I put let's say I had someone who had fear of dogs, and I put a dog in front of them, which was what we would have to do, is the dog a treatment or a tool? And so I look at VR as the same as that. It is a tool to enhance the treatment, just like any other psychological tool. And so insurance companies have been paying for it the entire time. And I've talked to, Brennan Spiegel about, the FDA approval and all that kind of stuff. And I said to him, I've had insurance companies that I really have not been on their panels. And I would take out what we call a single case contract with an insurance company to only provide service to this one individual. And I would explain that I'm doing VR with them. And I had no problems with any insurance company at all. So I don't see it as a problem. But VR therapy has done a few things in terms of my practice and how I see my patients. So I'll give you a couple examples. Very early on in my career with VR, I had a woman who drove out from Colorado to see me in New York. And she did that because she had a fear of flying, and she's been driving all over the country, but she was tired of it. And so she wanted to conquer this fear of flying. I spent 2 days with her, really flooding her and really working on her anxiety. She drove back to Colorado, and she's been flying ever since. I could not do that in standard therapeutic approaches. You know, I would never get that return on somebody that quickly. Give you another example. I had a guy who booked a trip to Amalfi, Italy, and then he looked at the itinerary and he realized everything is on cliffs, and he had a fear of heights that he never really resolved. And this was June. The trip was in August, and he said, "You got to fix me." And I said, "Okay, I'll take my best shot, but let's see what happens." So I saw him 6 times, and he went to his trip to Amalfi, and afterwards I contacted him and I said, "How did it go?" And he said it worked 80% of the time. He didn't still love heights, but he was able to do it and enjoy the vacation. So to him, it was a complete success. But I could never do that in 6 sessions again with the older standard protocol for working with anxieties and phobias. So what virtual reality has done for my practice is it increased compliance, it increased successful outcomes, it's cheaper, and because patients have that sense of control in the therapy session, they're not as overwhelmed. So, I mean, if I put somebody on a plane and they're stuck on that plane, but in virtual reality, if you're overwhelmed, you just remove the head-mounted display from your face and you're out. And so when patients understand that, they understand that they have some control here, and they're not powerless and they're not stuck, they actually benefit. And what we do know from the research is virtual reality treatments work as well as in vivo treatments in terms of dealing with phobias and anxieties. So it just makes good clinical sense in my book to use virtual reality for phobias and anxieties. Now, there are other people out there who are using it for a whole bunch of other things, autism, eating disorders, pain management, cognitive impairments, dementia, all sorts of things. But I focus mostly on phobias and anxieties. And when I first started, there were very few companies in this realm, but I have been keeping track, and I'm up to 44 companies in virtual reality in behavioral health. All right, that's significant. And you mentioned Walter Greenleaf. Now, Walter and I have been talking about this, and Walter's up to 200 companies in all realms of medical and behavioral health. He covers everything. So he does all the PT, the OT, medical training. That's not in my wheelhouse, so to speak, so I don't keep track of that. But clearly, the amount of enhancement in this particular field is incredible. And so VR has really expanded. Now, here's the downside from the psychological point of view. So I'm on Long Island. I have an office in Nassau County and an office in Suffolk County. And I, again, calculated that there are about 1,000 licensed psychologists in Nassau County and an equal number in Suffolk County. And just counting mental health, just psychologists. I'm not counting mental health workers, social workers, any kind of other clinicians. So licensed psychologists, there's 2,000 on Long Island alone, just the Nassau and Suffolk County, which is a lot. But I can count on my fingers the number of clinicians using virtual reality because it doesn't get incorporated into their practices for a variety of reasons. Many of them are fearful of technology. They get scared when you introduce something that has a technological orientation to it. I'm kind of an outlier in a sense. I'm towards the end of like almost retiring, but I'm not there yet, but I'm close. And I and my peers, none of my peers are really doing this. But I've always looked at technology as a tool in private practice to speed up private practice, to enhance both the management side and the clinical side. And so I've always been doing things ahead of the curve, so to speak. But my peers are fearful of technology, and because it's not part of their standardized training, they weren't trained in VR, they don't really want to jump into it. Whatever works, and that's what they do. And also, there's this misconception that many people have that VR takes away the interpersonal quality of clinical work, and it doesn't. I still have to be very involved with my patients, and I do a lot of face-to-face with them, which is now kind of in trouble. But I have to be involved with them. I have to talk to them, because therapy really, to me, is teaching them how to recognize their bodies, recognize what they're thinking, give them tools and skills to reduce the anxiety and stress they're experiencing, normalize it, because people think that they're the only ones walking around with that anxiety, and clearly that's not the case. So there is a lot of clinician-patient involvement in VR still. Now, I do have the capacity now to do VR remotely. So I could do the same thing I would do face-to-face and have somebody in their home using their head-mounted display or standalone, Oculus Go or something like that. And I can control their Oculus Go from my computer in my house. Now, when I do that, it works very well, but I don't get the feedback I need. So I get subjective units of distress from patients in terms of their self-report, but I can't get galvanic skin response or heart rate variability, which I also use to measure what's going on with them, in spite of the fact that they may say I'm doing fine and I'm okay, but the biometrics say otherwise. So I know that there are people who would come out of the head-mounted display and say, I felt fine, but I now have to clean the head-mounted display because they sweated it up. So they weren't really fine. But I could tell that their bodies are reacting. And so I don't get that piece because I'm not there, but I still get the subjective units of distress scores, and that helps. So it has evolved into this remote because of COVID-19, and the coronavirus has created a demand to modify the system so we can meet people's needs without having to do it face-to-face. And I think, in reference to COVID-19, it's going to increase virtual reality and alternative reality. It's going to increase the processing of it and the development of it, because we now need it more than we did before. And I think the necessity is going to make this a much more viable field. And probably with 5G, when that comes out and is widespread and things can be streamed, I think that's going to develop a whole new line of environments for people to use virtual reality and alternative reality and XR, whatever you want to call it. Because I don't think we're going backwards. I think we're going forwards. And I think from the clinical perspective, maybe it's going to push a lot of clinicians into the 21st century because many of them are really stuck with old technology or no technology at all. And so I think this is going to speed up the process and hopefully, turn this into a much more viable, more mainstream acceptable platform, both for clinicians and for researchers and educators. So that's my story, and I'm sticking to it.
That's great. Thank you, Howard. Maybe SciAS needs a module to get psychologists over their fear of technology. Maybe we can get that going. Okay, next up, I guess we'll switch from provider to developer. We have Mia Smith, who's a VR and AR developer, and I will let her introduce herself more fully. Take it away, Mia.
All right. Hi, everyone. Thanks, Joe, for the introduction. My name is Mia Smith, and it's really nice to meet you all, and it's an honor to attend HIMSS this year as a speaker. I'd just like to thank, is my connection okay? Okay. I'd like to thank Joe and Mark and others in charge of the conference for allowing me to have this really great opportunity. And since I'm a little bit newer to the field than the other presenters today, I'll just be discussing a bit about my journey to get where I am now and what I currently do as the XR interaction designer at a technology healthcare company called Behavior. Our main offices are located in Kentucky and Tennessee. I'm in New Jersey, so I'm working remotely for the time being. If you'd like to learn more information about us or anything that I've discussed in my presentation, feel free to just visit our website. We're BEHAVR. A lot of what Howard actually just discussed about CBT is some of what we focus on as well. So that's exciting, and it was helpful to kind of have a bit of a background already highlighted. So just a quick intro about myself. I graduated last spring in 2019 from Skidmore College in Saratoga Springs, New York. I earned a BA with magna cum laude honors in psychology and a minor in fine arts. I'm also a member of the Psychi International Honor Society in Psychology, and as I mentioned, I'm the current XR interaction designer at Behavior. I'll get a bit into that in a bit, but I've always really had a passion for learning and helping my community. I focused my studies on clinical psychology, and I knew I wanted to make a difference and help others affected by mental illness and other health conditions. I've been fascinated by the way technology can improve our quality of life for years. And as the highlight of my academic career at Skidmore, I actually created a VR simulation in Unity 3D that was intended to emulate VR exposure therapy for patients with anxiety disorders that Howard just touched on a little bit. I was in an anxiety disorder research lab and also one on music cognition. And I completed 2 amazing internships. One was at a kind of like an art therapy, expressive arts place downtown in Saratoga Springs. It was for adolescents, and we explored relationship topics through music and art. And I also had an internship at the Four Winds Saratoga Psychiatric Hospital on the children's unit. And that was a really incredible experience that, allowed me to interact directly, with children who are struggling with mental illness. And it really just confirmed to me that this is exactly what I want to be doing. This is the population that I want to be involved with and help. And so now I work at Behavior, a really amazing company, and we promote lasting behavior change through the use of immersive tech. And so, very luckily, I'm doing exactly what I set out to do when I graduated, thanks to amazing mentors and great people who I've gotten in touch with and who have encouraged me along the way. So just a little bit about my journey to how I've gotten to where I am. I've definitely traveled an interesting one. Up until about my last year in college, I didn't even know what I wanted to be. I kind of went all over the place. I grew up an artist my whole life, and I was a musician as well. I performed in statewide competitions and had my work in regional exhibitions. I attended the Maryland Institute College of Art my first year of college, actually. And others always describe me as creative, and I never thought I'd end up in a field that, involves technology, programming, statistics, all that. But there really is a lot of creativity in fields that are conventionally thought of as, strictly math, science, or engineering based. There's a human side to all of this, especially when we're dealing with patients in a psychological setting. And because VR is incredibly immersive and, just a sensory experience, including visuals, sounds, body awareness, creativity is really, necessary kind of as a stepping stone to make sure that the right response is, elicited from patients, and then they get the most effective treatment that they can. So from the visual design to the back end storyline, it's really important to, make sure it all comes together in an effective way. And this does include, design and being creative and really accounting for, the human side of all of it. And being able to craft these perfectly is really important. So as I mentioned, I am right out of college, so I'm just beginning, and we all have that aha moment when we know exactly what we want to do, whether it's in school or whether it's a hobby, or kind of whether you just stumble across it unexpectedly. I have two aha moments. The second one makes a little bit more sense, but the first one was when I was about 9 years old, and I happened to see a movie some of you might know called Bicentennial Man on TV. It was a 1999 movie starring Robin Williams, and he played a seemingly ordinary house robot named Andrew. And over the course of the movie, he developed emotions and human-like qualities, and he ended up, having relationships with other people. And for some reason, I'm still not sure of, that movie just spoke so profoundly to me. But over time, this really developed into my fascination with technology and psychology, really just stemming from that movie. And it led me to take courses about the philosophy of artificial intelligence, computer science and programming, game development, and, ending up majoring in clinical psychology and learning about clinical VR, which is a perfect, blend between that and technology. And I really wanted to be a part of this, huge movement that was helping others, also in reducing stigma and treatment barriers to mental health. So my second aha moment that makes a lot more sense, I happened to experience clinical VR for the first time in a psychological disorders course that I had in college. It was a well-known one that targets the phobia of heights. So you kind of walk out of an elevator onto a wooden plank and you're about 50 stories above the ground, and it's very terrifying. I will attest to that. Right after that, I went to my professor. I told her that's exactly what I wanted to go into. And going back to my comment earlier about kind of having, a bunch of different paths that I thought I could go down, I felt like clinical VR was really the marriage of everything that I wanted to be. And I was grateful that I had found that field. It involved the art that I had talked about growing up loving to do, and that I had a passion for, the psychology that I fell in love with, and this technology that I've been fascinated in since I was 9. I was so impressed that my brain was fooled by what was basically a 3D video game. I'll be honest, I was sweating when I was, over these 50 stories. My hands were shaking. I was really nervous, and I thought, that's going to be powerful. You can use that to do really powerful things. And obviously doing it, in a clinical psych setting to help patients, that was something I was really interested in. And I had, really now discovered this incredible field. I could create any world I wanted to. And I really wanted to use my skills to help better others' quality of life. And so just a bit about VR and its advantages. So VR is an incredibly powerful tool when it's used for this purpose. And when it's used to help patients in a clinical context, there are a lot of advantages. So over the last decade, VR has been introduced in psychotherapeutic settings at an increasingly fast rate. Sometimes it even outperforms traditional, psychotherapy techniques. Some disorders and conditions that might benefit from VR include PTSD, anxiety and phobias, depression and paranoia, and there are a lot of others. And it's used in many situations, but also for physical rehabilitation as well. And so in college, my focus of study was how VR can be used to complement traditional exposure therapy and psychology. So just a little bit of detail about exposure therapy. It consists primarily of controlled, systematic exposure to a distressing stimulus that a patient might have. And the intention is to gradually diminish the patient's anxiety about this stimulus over time. Common fears we might think of include large crowds, heights, anxiety-provoking social situations. An easy example of exposure therapy to envision might involve, a specific phobia where a patient, has a really intense and irrational fear that's, disproportionate to the posed danger that that thing actually presents. So funnily enough, like Howard, I'm just going to give the example of dogs. So for example, if somebody has a phobia of dogs, even though, a lot of dogs are cuddly, they're friendly, most of them don't hurt us, the person could have had a traumatic experience years ago that, you know, might cause panic attacks now whenever they see one. So in real life exposure therapy, I guess typically the therapist would expose the patient systematically to this fear. So over time, you know, it could take weeks, months, years. It really depends on, you know, the patient. But first they might be shown a picture of a cartoon dog, and then a picture of a real one, a video, so on and so forth, until one day they're able to actually meet the dog in person. Sorry, 1 second, my camera froze. Okay, I think we're good. So while I said this might take months or years, it's really been proven to be an effective technique for a number of reasons. One of them being that it helps patients restructure their avoidance techniques. And so avoidance is one of the strongest reinforcements that, you know, promote these unproductive behaviors. By removing this stressful stimulus, your behaviors are strengthened, which just makes sense. You know, the more a patient avoids these situations, the more likely they're going to continue doing so in the future, because avoiding it is like an addicting sense of relief. It works. But, you know, it's not entirely an effective way to work through the stressors, even though, you know, it might seem easy and like an attractive solution. So according to the Yerkes-Dodson law, once a patient is faced with this distressing stimulus in therapy, he'll attempt to engage in safety-seeking behaviors once he's in this uncomfortable situation. So really that law says, let's say, right now I'm publicly speaking. So let's say you're giving a speech. Most people will feel some level of anxiety that's healthy. Some anxiety is healthy. It makes you a little more alert, and it makes you perform better. But there comes a certain point at the very top of the graph where your anxiety is debilitating and your performance kind of just, you know, goes down significantly. You're so anxious that you want to run away. And so that's kind of what's going on when patients are, you know, in the middle of experiencing a panic attack when they're confronted with the stimulus. But one of the primary benefits of VR is that it lets the patient experience this in a safe virtual world in the therapist's office, in a controlled environment. And this helps to eliminate the possibility of any unexpected events to happen during the exposure. The patient also has complete control in the process of confronting and overcoming their fears, because they're able to undergo their treatment at a pace that they feel comfortable with. And VR also allows for some customization. It allows the patient to tailor the experience to their own emotional needs and responses. If the symptoms are severe one day, the exposure intensity can be lowered, you know, either by request of the patient or by the clinician. And if the patient is feeling great, maybe the therapy session would lean toward challenging him a little bit. A really easy example to kind of envision that I like to use in terms of this customization, in terms of feasibility of exposing the patient to their fear in real life, is, let's say, a war veteran is a patient. It would be a little unreasonable, I guess, to put them back in an environment that would simulate war in real life, you know, send them overseas, you know, of course not. So, you know, if that was the, you know, specific stimulus that was really causing this person PTSD and panic attacks, being able to create that world, you know, as a customized world tailored to their needs in VR would be very effective, because it's targeting their exact fear. And so this is ultimately to ensure that their real life experiences match what they've worked so hard to achieve in the virtual world. So just really quickly, just a little bit about behavior and what we do. And so, as I mentioned, VR with used along with traditional psychotherapeutic techniques, there are a lot of compelling advantages. At behavior, we design, build, and we sell digital wellness and digital therapeutics to address chronic stress-linked conditions. And our VR experiences are really aimed at empowering individuals and lowering barriers to health with this personalized educational content. So our content is a bit personalized, as I just mentioned, which is very effective. We capitalize on emotional regulation skills and stress reduction techniques for our patients as well. Our programs engage all 4 systems of learning in our brain. There's the cognitive system in the frontal lobe, emotional system in the amygdala, experiential system, and the behavioral system as well. And we offer some really amazing content. I might be a bit biased, but I think it's really cool. We offer our core balance program. We utilize mindfulness, exposure, cognitive behavioral therapy, CBT, emotional regulation, and relaxation methods. Many of our programs are led by clinicians where they have full visibility into the patient's progress. So it's a really great two-way street with a lot of open communication. Currently, our 4 general wellness programs focus on pain, stress, addiction, and a perinatal experience. And in 2021, we're looking to create things surrounding anxiety, opioid and substance use disorder, depression, and PTSD. So we really have a wide range, and I think that's amazing. And, VR offers us that opportunity to create our own world. We can defy the laws of physics, have things appear out of thin air, have music play along to our body movements. And so it can really just be so powerful and really effective. And, to make this effective, we just have to make sure that, these elements make sense to create the experience we want. And that's kind of my role. Creating that experience is down to a science. And that's pretty amazing. And so just a quick last note about a little bit about my role at Behavior. So as the XR interaction designer, it kind of involves a little bit of everything. I work with the development team, the creative team, and the product management team to determine how our programs can be as effective as possible in all those areas. And like I had mentioned before, I managed to pull in all my interests together in my career, which was really lucky, and it's just an amazing experience. And one final note that I know Joe wanted me to touch upon a little bit. In the larger community, something amazing I'm a part of is my AltSpace VR channel. It's called XR Creators Unite. I've been running it since November of last year. Tim was actually a presenter this past weekend, which was very cool. But every Saturday I hold events that gather our community members and others who are interested in VR and AR. We share ideas, learn skills from others, make connections. We host featured speakers every other weekend and we hold debates and group discussions surrounding current topics and technology. It's a lot of fun. It's a really cool way, I think, to meet some inspiring people in the community. If you'd ever like to attend the event or be a speaker even, we usually have a pretty good amount of people showing up, so please feel free to reach out. But it's a rewarding experience that I hope I can continue for a long time. So with that, I think I conclude my presentation. And thank you all so much. Thanks, Joe.
Great, thank you, Mia. I appreciate that. And yeah, it's very fun to be in AltSpace and experience sort of a virtual space. And if you haven't been in it yet, it's worth a try. Next up, we have Dr. Robert Lewis from Hoag Hospital. And on the topic of aha moments, I guess I'm going to jump on that and just say that I saw your Dr. Lewis's presentation at HIMSS a couple of years ago, talking about what they were doing at Hoag with VR for education for patients on their own conditions and the surgical approaches. And from a business and from a cognitive and from a patient perspective, it was definitely an aha moment for me. And it's one of the reasons I started to really dive in more to VR. So I will hand it over to you there. Thanks.
Thanks so much, Joe. I'm excited to be here today. Can everybody hear me okay? Okay, I didn't get the memo. I know you guys had done some prep calls and stuff like that. I didn't get the memo that this was more of a conversational base, so I'm going to have some PowerPoint slides just as visual references because I've got a lot of data from the stuff that we've deployed over the last 5 years at Hoag. Specifically what we specialize in is optimizing care delivery with advanced technologies. Just a bit of background about me. I'm a neurosurgeon. I was recruited to Hoag 6 years ago to bring advanced technologies for minimally invasive brain tumor surgery to Hoag, and we've done that very successfully over the past several years. And so I'm going to switch over views here to my my slides. And can everybody see me there? I'm hoping so. Yes. What I'd like to start off with the video here, which kind of really explains the work that we started off with and how our journey began.
On Monday, June 2nd. I felt the worst headache in my life, like an ice pick driving through a skull. A CAT scan revealed a bleed in the side of my head, the size of a softball. The option to stop the bleed was to have a craniotomy to remove it. Being completely out of control is terrifying.
It's difficult to talk to patients about brain surgery because it's very abstract. We're combining delivering difficult news about a scary diagnosis with the additional fear of not knowing what to expect and not being able to understand what it is I'm explaining to them. When we show them the model, when they fly inside their own brain, they can see the structures, they can see the tumor, they can see the aneurysm.
This device creates an experience for the patient where nothing is unknown anymore. I'm not a doctor, so I couldn't understand what they were trying to tell me because I had never physically seen a craniotomy before. It's so hard to wrap your head around what they're about to do. When I put on the goggles, my surgeon asked me if I was ready to fly. In the moments where they were telling me really terrifying things, I also felt a little bit of peace from the way that it was being presented. I was able to, in real time, see inside my brain. I was physically there with them, looking at exactly what they were trying to communicate.
Before surgical theater, preparing for surgery was literally me sitting over a cup of coffee, kind of thinking, okay, I'm going to do this. And then I remember that the optic nerve is here. But those preparations were a kind of ad lib. Now, with 360-degree 3D reconstructions, we're able to be inside that environment, which is as close to brain surgery as we can actually get without being there in the operating room. The advantage that the virtual planning and rehearsal brings to our readiness for surgery is the ability to simulate multiple different approaches. In a real patient, we don't get to try that more than once. We only get one shot at it. In the virtual model, we can do 2 plans, 3 plans, 5 plans, and see which one is the best for the individual patient. Make the bone look a little more like bone, so it's not translucent at first. Now that I can see the frontal sinus, I'm planning it, yeah. Bring the microscope. When we're in the operating room and we get to the time of surgery, because we've done the preoperative rehearsal, it kind of feels like deja vu, like, okay, I've been here before, I know where the important structures are going to be.
So here we are, we're coming up to the back of the tumor right here. This would be a good place to do an overlay. Make the tumor more translucent.
I was at the hospital in the ICU for 10 days, and I had 2 angiograms, 2 MRIs, 2 CAT scans, and a craniotomy. I had a risk of having epileptic seizures for the rest of my life, not knowing that I'd ever be able to drive a car again, that I would ever be able to run again. But I would say the biggest testament to how everything went was the fact that I'm sitting here today. It was nothing short of a miracle. It made me more grateful for each and every moment that we have. We experience life in 3 dimensions. Why should our medical care be any different?
So I love to show that because, from a patient's point of view, to see what it's like, in this case, not stress inoculating them against being on an airplane or being in a height, but stress inoculating them prior to going into their brain surgery. And this patient, Danielle Collins, was so moved by this that she's now started a foundation called the Empower 360 Foundation, which is a philanthropic foundation whose mission is to spread the awareness and availability of VR and AR technologies in healthcare. So in this one patient's life, it's made such an impact. And the difference really is, when I look at this, is which view is easier to understand. The traditional ways that we show patients MRIs and CT scans, this kind of looks like a Rorschach blot, okay, it's a bat, or maybe it's 2 witches kissing, versus, when you look at the 360 VR image, it's very obvious, even to my 7-year-old daughter, where the tumor is. And so explaining it to patients, in this case, a picture is worth more than 1,000 words afterwards, because it allows them to be fully engaged in the decision-making process. And in fact, in some cases, it improves the consent process so significantly that it actually spares medical legal litigation, because with a 360 fly through like this, that it's difficult to claim that they don't understand the risks of the operation, because it's so clearly explained to them using a virtual reality model. So my initial experience in virtual reality was in surgical rehearsing and planning, but my aha moment came when the patients started asking, hey, that's my brain, I know you're using this to rehearse, can I see it? And so what we did is we actually studied the impact of virtual reality rehearsal and planning for patient engagement on the patients themselves. So this is a comparison of using patients who underwent a consultation with a 360 VR model of their brain as compared to national average. And we're getting 100% of our patients now prior to brain surgery saying that their doctor explained things in a good way, as compared to 77% of the national average. Again, patients who giving a hospital rating a 9 or 10 out of 10, a 97% compared to 73% on the national average, and definitely would recommend, yes, the hospital, significantly higher than the national average. Why is this? Because it improves their level of understanding. Well, the best way to demonstrate this is that patients vote with their feet. And I presented this. This may have been the data that I presented that Joe had seen. So we did a 3-year longitudinal study, starting with no virtual reality. So patients just got the standard consultation where I'm showing their black and white images and drawing a picture of the brain, versus over 2 years transitioning progressively to patient-specific virtual reality models. So when a patient comes into my office, instead of seeing their MRI in black and white, they get their individualized brain built in VR, and they fly through that brain with me and their family members. So we can have up to 4 people in a shared VR experience flying through their plan for brain surgery. Well, what we noticed was the satisfaction scores are one thing subjectively, but patients vote with their feet. Prior to the virtual reality consultations, 64% of my patients that I recommended surgery for were staying, meaning the attrition rate or the outmigration rate of patients leaving Hoag and going to Cedars, UCLA, or Stanford, which are less than an hour away, was 36%. That's an awful lot of patients we're losing to regional hospital systems, because the patients, felt that they were going to get better care there. When we implemented the virtual reality in the patient consultation room, the attrition rate dropped to 4%. That is a remarkable improvement in patient retention and surgical conversion, because it demonstrates the power of this technology to engage the patients and feel that not only that they understand, but that they are actually a part of their own decision-making process for surgery. And it's such an odd thing, because we're going through these terrible moments where we're explaining to them, what the surgery is going to be, and it's such a scary moment for people, and they're finding out they have a brain tumor, and flying in their brain is the shift in their tone and in their affect is unbelievable, because all of a sudden it's like, wow, I get it. Let's get this thing out of there. And so this is actually just recently published. I presented it a couple of years at HIMSS and at Becker's Hospital Review, but just recently published in neurosurgery to demonstrate the efficacy of this. It has also been replicated outside of neurosurgery for interventional cardiology. Also here at Hoag, significant improvements in patient retention and conversion rate for the TAVR procedures from 86 to 100%, and for the Watchman procedures going from 68 to 92%. So again, the power of virtual reality to engage the patients, because it improves their experience and level of understanding, and truly gets to these ideas of informed consent and shared decision making. The word that I use is it accelerates patient condition health literacy. In other words, we're trying to get them from the average American has a 9th grade education when it comes to health. We're trying to rapidly accelerate them to at least an associate's degree, if not a bachelor's degree, in their specific condition. And there is no better medium or tool to use that than individualized patient virtual reality sessions. This is example of that data. So before and after virtual reality for adult neurosurgery, this is level of patients who rate their level of understanding a 9 or 10 out of 10. Before VR, 28%. After VR, almost 90%. For thoracic surgery, 60% up to 95%. For interventional cardiology, 26% up to 88%. Again, emphasizing how powerful VR can be in engaging those 4 learning systems and helping patients accelerate that learning curve and truly understand their own condition and therefore be a more important part of it. I always, use the expression, and I don't remember who I got this from. It's that, I tell patients that I am the chief medical officer and the chief operating officer of their health, but that they are the chief executive officer. They need to make the decisions, but in order to do that, they need the information. So at providing that as the chief medical officer or the chief information officer, and then once they make the decision, the informed decision, I will execute the plan. Forbes magazine, which isn't in the business of medicine, but is in the business of business, in fact, rates virtual reality as the #1 technology for patient experience in healthcare. And this is what we've seen in neurosurgery. And as a result of the significant, substantial success we've had in neurosurgery, it has led to, you imagine retaining 30 or 40% more neurosurgery patients has a large impact on the hospital bottom line, which has led at Hoag to significant reinvestments in this technology for us to be able to expand use beyond neurosurgery and beyond surgical specialties. And in fact, as a result of this, over the past 5 years, about a year ago, I was given an additional role as director of XR development. And so part of that is to develop a strategy around how to wide-scale deploy VR and AR technologies within our hospital system. So we've gone to, for surgical imaging and anatomy, we've gone to, rather than individual stations, we've gone to this enterprise-based solution where all of the models for thoracic surgery, spine surgery, urology, hepatobiliary surgery, brain tumors, cardiothoracic surgery are all built in a single location and then routed to the individual clinics so that each of our surgeons has the ability to engage their patients using virtual reality and therefore retain even larger and larger percentages and have better patient satisfaction because of the enhanced patient experience. As I moved into this role, and I continue, of course, as an active neurosurgeon, but as I developed this role as the director of XR development, the idea at the center core, we wanted to develop a strategy which would allow us to put these different technologies into different buckets or different spheres as to where they will be useful or where the evidence stands to support their use. At the core of this model, as we demonstrated in neurosurgery and interventional cardiology, is that by its nature, virtual reality improves the patient experience. It's an immersive technology which patients enjoy, and therefore they are happier for it. Moving in concentric circles from there, the first sphere is deploying technologies which are evidence-based, meaning there are some technologies out there which there is a mountain of evidence to support their use, and yet still are not either FDA cleared nor paid for by insurers. At Hoag, we have decided we just don't care, and we are going to, using hospital funds and philanthropic funds, deploy technologies which are for the benefit of the patients, which are already evidence-based. An example of this is for pain. There are more than 250 clinical trials demonstrating the efficacy of virtual reality for pain. I'm going to show some of that data. In the next sphere beyond that, research, we have a robust research institute. So there are some additional technologies which are not quite proven enough that we're just willing to say, yes, let's deploy this wide scale, but that we are willing to and are actively studying the effect of these on patients. And I'll show some examples of that. And then finally, in the outer category, develop our clinicians will present unique clinical problems. We'll look for a solution in the marketplace, but if it isn't there, we will then go and work with a company partner, such as Behavior, to develop a new technology or new program, which over time, which can solve that clinical problem. So Mia briefly mentioned the perinatal program, and I'm not going to say much more about it than that, other than that there is a big news coming in the next week regarding an example of this development partnership where our hospital system engages with development partners and our clinicians to actively build a product which we think will serve clinical needs as well as the needs in Orange County, in our community, and beyond. So Within the deploy category, though, as I said, our nation is at a crisis. This is drowned out by the COVID pandemic, but actually probably being made worse by it. The fact that we're losing 50,000 Americans a year now to opioid overdose, and the fact that a single day of opioid administration as an inpatient, this is data from the CDC website, leads to a 6% dependence at 1 year. If a patient's hospitalized for 5 days, which is pretty average for certain types of surgery like knee replacement or spine surgery, the risk of dependence, these are otherwise opioid naive patients, the risk of dependence at 1 year is 10%. That is a remarkable statistic. That means 1 out of every 10 patients that stays in the hospital and gets inpatient opioids is going to be dependent at 1 year. That is not acceptable. And we have to have additional methods and tools to stem the tide of opioids. We know as physicians we caused this. 20 years ago, we were told you guys are under-treating pain. Pain is the 5th vital sign. Stop, you start giving out more pain medications. In fact, we were told that our satisfaction scores were dependent on it. And so the simplest thing to do was, you know what? The easiest way to get patients happy is to give them more opiates. And now we're seeing the significant negative effects of that. I think that is going to only get worse as COVID comes out. Patients no longer have access to their doctors. Instead of seeking the normally prescribed and regulated pain medication they're going to get, they're going out onto the street and switching over from prescribed opiates to more readily available heroin and bathtub-made fentanyl. So we have to make a dent here, and I believe we can. Virtual reality has been studied significantly, and this is why I put it in the deploy category, in almost 500 published articles, including 20 experimental trials, both for acute and chronic pain. And the key take-home of this meta-analysis is that most studies definitively demonstrated that VR helped decrease pain both during and after medical procedures and surgery. I doubt very much that there were 500 clinical trials published before they allowed OxyContin to come onto the market and become FDA approved and cleared. It's just that the machine behind the pharmaceutical industry can pay $1 billion, including $100 million in lobbying costs to get it across the finish line. However, we know the effects of those are significantly scarier. So I love to show this slide of the effect, the mean effect in duration efficacy of a virtual reality session versus a standard dose of fentanyl at 50 micrograms of fentanyl. So for a mean reduction in visual analog score, approximately 3 points for either 50 mics of fentanyl or a 15-minute session in VR. The fentanyl does last a little longer, mainly because we only generally keep patients in a VR session for about 20 minutes because they do tend to sometimes get what's called cyber sickness or some nausea associated with it. The cost of virtual reality, there's an assumption here that if you have a standard headset, with it, for example, if you take the cost of an applied VR headset and space it out over a year, and then say that after 100 uses you throw the headset away, which doesn't happen, but I had to make an assumption that you would usually get way more uses out of it than 100 uses. Even at only 100 uses, the cost of deploying virtual reality is significantly less than the patient. Now that does not include the cost to the patient on their well-being. I have another slide where I list the negative side effects of fentanyl, which is hundreds and hundreds of different things, including addiction, overdose, and death. You compare that to the known adverse effects of virtual reality, which can include nausea, eye strain, neck strain, and potentially in epileptics, a 1 in 4,000 risk of seizure. And I actually believe that could be eliminated now as well, with the refresh rate on the modern headsets being less like a strobe light and more like a television. I think that actually is a study that we're actually getting ready to perform in our epilepsy monitoring unit. We're taking headsets on patients we're trying to get to seize and putting them in standard modern VR headsets and seeing if indeed that the exposure to VR does trigger a seizure. And it's the ideal patient population to study it, because I think that the data that made a black box warning against VR is actually old and should be removed. That's a small matter, but the idea here is that the risk-benefit ratio of deploying virtual reality for pain as compared to the current standard of care, which are addictive opiates, which kill 50,000 people a year. This is a no-brainer. The FDA, I'm on the committee for this. They're way behind the curve. They want a sham VR experience where, you have to put them in another VR experience to prove that it's your VR and not VR that takes away their pain. Do we really care for if it's acute pain? If it's lowering their dependence on opiates, why do we need it to be that they have to, by comparison, watch a violent video and make sure that it's not just the experience of being? I think they're off track with that. Fortunately, I'm speaking to some of the large payer groups as well, and I think that the payer groups don't actually care whether it's FDA approved or not, because they know, everybody knows conceptually and based on the evidence that there's benefit here. One of the ways for chronic pain is teaching patients about their pain. This is called pain neuroscience education. This is something that Behavior has done quite a bit of work on, even before VR, working with evidence in motion, Dr. Adrian Lowe. There's level 1A evidence in medicine. This is the highest quality of evidence we have that procedural pain knowledge has a significant impact on pain control and recovery time, and that patients who opted out of procedural pain education had longer hospitalization and more pain management and poor pain management. This is level 1A evidence, so could not be more clear. How does this work? It decreases their cognitive aspect of pain, so the time spent thinking about pain. It decreases the worst sensory, meaning the sensation, the physical sensation of pain, as well as the emotional or unpleasant aspect of the pain. Mia mentioned this before, but as a brain surgeon, I speak about this regularly. Why is it that you can't just use pain neuroscience education on a paper and pen format or on a 2D digital screen? It's because virtual reality engages all 4 learning systems of the brain. Typical learning methods, pen and paper, or writing, drawing something out, and watching a video, only engages the cognitive system. We see this in Zoom-based physical physician visits versus in-person visits. I'm not there with the patient. I can't smell the fact that they, or ammonia is leaking out of their skin because their hepatitis is out of control, or they're in cirrhosis. I can't really see that their eyes are bloodshot, or that their eyes are sunken in, or that they're twitching below their feet because they're off of their meds. So you're significantly limited. There's a bottleneck of information that occurs in traditional forms of learning, television or videos or reading, that occurs, that virtual reality by nature of its immersive specific content unlocks all 4 of these systems: the cognitive, the experiential, the behavioral, and the motivational, and allows us to accelerate the learning curve and move towards behavioral change for the betterment of health. What we're trying to impact here are the behavioral determinants of health in some cases. That these patients, if they're motivated and if they understand why, it's like, if they don't understand why, it's like telling a 3-year-old to eat their vegetables. Well, because they're good for you. We can't just tell them as a doctor, this is good for you, do it. We have to get them to understand why, and virtual reality for learning that, and then for getting them motivated. So the platform of Motivate, Educate, Activate is really the basis for getting these patients motivated to behavioral change in their own lives. At Hoag, we've gone wide scale with this. We've spent probably $10 million in the last few years deploying virtual reality across a number of different sectors, including preoperative planning and rehearsal. That's probably the biggest sector, intraoperative navigation, patient engagement, medical, legal, and consent, physical therapy, pain management, meditation and anxiety, as well as nursing and staff wellness. I funded for the nurses a virtual reality guided meditation room to help them during the stress of their day to take a break and use a VR guided meditation to give them to improve their burnout, to help them prevent compassion fatigue, as well as to get them ready to go back to their work. And actually, we're just getting ready to publish the results of that study. It had significant improvement on our nurses in both their workplace satisfaction as well as their perceived level of burnout. There have been some operational hurdles in this. Of course, there's infection prevention, which has become increasingly a concern in the COVID-19 era. We had to get nurse buy-in, physician buy-in, patient buy-in. Protected health information, of course, is a concern when we're collecting that. EHR compatibility is something we'd like to work towards in the end, which I think will help take some of the data gathered and plug it into the patient's EMR. And then the big challenge that we're dealing with now, I think the biggest hurdle that we have is reimbursement, because I'm very, to toot my own horn, I'm very good at raising donor funds from this in Orange County around these initiatives, and I will continue to do so. But that's not necessarily a scalable model in all communities, but it is in the addiction space. It is in the pain management space, because everyone in this nation has lost a friend or relative to an opioid overdose or a drug overdose. And so getting donor funding around that is one of the ways that we can help get this moving forward, in addition to having conversations with the payers about, listen, for you guys, this should be a no-brainer. If we save 1 out of every 100 patients from getting hooked on opiates, it's well worth the expense at $50 or $25 a use. If you pay for it like Tylenol, $25 per use for a headset in the hospital or even at home, each patient that we save from opioid addiction is a life that can go on to do something better. Some of these operational hurdles are accomplished using other parallel technologies. At Hoag, we use CleanBox technology to decontaminate the VR headsets, literally rolling the carts from room to room, even during the COVID-19 era, using this because this technology specifically has been proven against the SARS-CoV-2 virus to decontaminate both porous and hard surfaces. So we've deployed this wide scale at Hoag Hospital as a solution to both alleviate patients' fear of getting a headset being passed, but also solve the problem. And this was signed off by the director of our infectious disease, who also is captaining the COVID-19 strategy ship. We got nurse buy-in by allowing the nurses to have a chance. And I said we did a year-long study allowing the nurses to see the benefit in themselves and how using these virtual reality guided meditations helps them even after a 10-minute reset. I mean, essentially here what we're teaching is meditation in a box. We're teaching people to guide themselves through, to reset and be able to calm their sympathetic nervous system, activate the parasympathetic nervous system, and be able to approach a problem more rationally or deal with their pain and dial it down using descending control of pain pathways. So during COVID-19, I had started the idea this year with 15 strategic initiatives for XR deployment at Hoag. Of course, COVID-19 hit and it upended a lot of those because many of them were around surgeries which were then canceled because of the elective surgeries being canceled. So what we did is took the technology which we were ready to use and took 8 of our nurses, which would have been furloughed, and put them to work deploying VR wide scale throughout the hospital. We are solving the problem of both pain management as well as isolation. Remember that right now, these patients are not allowed visitors in the hospital. They're isolated in their rooms, afraid and alone, and the only visits they have are from the nurse coming in to check on them. So we decided to use virtual reality as a method both to treat pain as well as decrease stress and isolation amongst our patients. Over 3 months, we've gathered data on over 500 unique patients, 610 sessions in just 3 months, with an average range of 18 to 98, all patient types. Again, average reduction in VAS score of pain of 3, and average reduction in VAS anxiety score of 2 over those 502 patients. Just a couple of snippets from what they said. The patient said, "This is the first time I've been able to sit up and eat since being admitted. No pain during VR, very relaxing, helped me fall asleep. I cried because I could swim and because my breathing influenced the tree." This is one of my favorite ones. It's a 60-year-old male who did a testimonial for us who was recovering from spine surgery, who said, "With the aid of VR, I've even been able to better control my pain and work through it, and I was able to reduce my pain medication by half." That is the target that we are channeling here. That is the goal that we started out with to capture. And it is not that every patient will be able to reduce their pain medication by half, but it doesn't have to be every patient. There is no panacea. There's no snake oil, which is going to cure everything. But this tool we have demonstrated in many forums as a powerful one to engage and educate patients about their planned surgery, to decrease their stress levels, to help them regulate their pain and beyond. And we're getting quite a bit of press coverage with this. this. In fact, this local article was then picked up by Forbes. This is a little, when at the time it had over 25,000 views. The video that I showed at the beginning, just so you get an idea, with the patient, got over 1.5 million views on YouTube. So that, I'm actually not of the social media generation, but anything that generates that much interest on the internet obviously is having an impact, which gets patients excited about learning about these new technologies and spreading the word. So I know that I'm kind of preaching to the choir here, but these technologies are real and they're available and they exist now. This is just a little bit of a preview of things that we are currently developing that are in deploying virtual reality for pain management in the emergency room. This is as part of a program to become what's called a California hospital compare opioid safe hospital. So there's a designation that you can apply for as an opioid safe hospital. And one of the specific criteria in that designation is deploying virtual reality for pain in the emergency room and at least one other setting. Using it during chemotherapy infusion to help patients calm their anxiety. Using it to reduce opioids after spine surgery, knee replacements. We are deploying something called Mind Maze in our acute rehabilitation unit, which is an advanced level digital therapeutic, which we're able to, it's play therapy where the patients interact with the dolphin that's going to be installed in the next month. And then of course we are, a little bit of a plug, we are hosting a virtual reality for pain symposium. It's now being hosted. The virtual reality symposium is being hosted virtually on October 9th to spread the word specifically around the different types of pain: acute pain, chronic pain, procedural sedation pain, labor pain. All of these things are going to be on display. What we are doing, how we're deploying them, and for ones that aren't already deployed or well studied, how we're developing them. Just to give you an idea, the impact of virtual reality has reached the national stage. This is me on stage at APAC, the American-Israeli Political Action Conference in March, right before COVID hit. In fact, I had COVID on the stage at this time. I had 102 fever while I was giving the presentation, and right before us was Mike Pence on stage speaking. So the Vice President of the United States, and then on comes virtual reality. So there were more than 10,000 people in attendance, and hundreds of thousands of people tuned in to watch this display of our virtual reality technology. So we know people are listening, and it is having an impact. And I just did, like last slide here, just to say thanks to our extended reality team. I am the executive medical director. I also have the executive director of operations. We have Walter Greenleaf, who's we brought as a special consultant, who has been like pouring gasoline on the fire here and really helped the program to grow. And we are further expanding our team as we speak to be able to offer these technologies to more and more of our patients. Thanks for your time, and thanks, Joe, for having me. Joe and Mark, I really appreciate the opportunity to speak today.
Thank you so much, Dr. Lewis. I know we're over on time. We probably could have done 3 hours on this topic or more, but I appreciate everyone's content, and obviously we'll table the questions, but we'll see if there's interest in doing some targeted follow-ups, and I will look to put some of the links to things either on the YouTube channel or on my LinkedIn, or a combination. If people want to chase down more information, please just hit me up.
Awesome. Thank you.
Thank you all very much.